Hi, my name is Rachel Aponte, and I'm a nurse with the North Simcoe Muskoka Hospice Palliative Care Network. I'm going to be discussing today terminal secretions at end of life. End-stage secretions are known to occur in about 12 to 92% of patients. So that's really a really grand number and could be very variable. The average time from onset of terminal secretions until death is between 11 and 28 hours. The question around secretions is whether they originate from the throat and salivary glands or from the lower respiratory tract, possibly due to pneumonia, pulmonary edema with cardiac disease, a cancer of some sort, or a disease that affects the respiratory system. Knowing the difference is important in determining the most appropriate treatment. Respiratory congestion can be caused by increased fluid in the airway. We call these oropharyngeal secretions. Could be from tracheal bronchial secretions, and this is a very normal occurrence. Could be from non-respiratory secretions, such as an aspiration of foods or fluids, or even saliva, blood, or exudate that maybe is being generated from a tumor within the airway. Decreased airway diameter can also cause an increase in respiratory congestion. This is when there's an increased resistance or turbulence. It could be caused from edema and swelling. It could be caused from smooth muscle hypertrophy. And it could be either intrinsic or extrinsic compression. So it could be tumor burden from outside the airway pushing in, or a tumor burden inside the airway constricting it in that way, causing the airway diameter to be smaller. The rate of ventilation can certainly cause some respiratory congestion, increased respiratory rate, altered rapid breathing patterns, and certainly the prolonged dying process itself can cause increases in respiratory congestion. So the disease process itself. Treatment is based on the cause. So for instance, if it's heart failure that is the cause of the respiratory congestion, then sometimes diuretics and ACE inhibitors can be helpful. If it's related to pulmonary edema, then Lasix and opioids would be the gold standard to try. If it's related to an infection, chest infection of some sort, then antibiotics can certainly be tried. If it's related to asthma, bronchodilators and anti-inflammatories are often helpful. If it's related to ALS, then it sometimes depends on what the origin of that those secretions are. If it's from saliva, then tricyclic antidepressants and anticholinergics can be helpful, and Botox at times. And as well, if it's because of bronchial secretions, if that's the origin in the bronchioles, then a mucin-reducing agent such as propranolol can be helpful. It's important to assess the patient, and a tool to use in order to assess the patient and assess the amount of respiratory congestion that they're having is to use a tool called the Victoria Respiratory Congestion Scale, or the acronym for that is VRCS. So this is a scale that goes from 0 to 3, and 3 is the most congestion audible at the doorway of a room, and 0 means no congestion at all. Congestion is absent when standing at the bedside. And this is just an example of what that scale looks like. So you can see on the left the rating 0 to 3, and how you can conclude that you have those ratings. And then there's instructions there on how to be able to assess that patient. So the staff member would stand at the side of the bed, slightly over the patient's chest. They turn his or her head about 30 centimeters from the chest and listen for several breaths. The staff member then moves to the end of the bed and listens again, and for several breaths, and similarly at the door of the room. And so based on what your findings are, then you in turn give a VRCS score. The management of respiratory congestion is something that often is problematic in the community and in hospital. Respiratory congestion is very distressing for the patient themselves as well as for the family members to be dealing with and hearing at the bedside. So it's very, very important to provide family teaching, reassurance, and support. It's also important to reduce the noisy breathing through the dying phase by decreasing the saliva, decreasing the mucus, and using anticholinergics. It is also important to reduce the non-secretion noises if it's distressing by sometimes decreasing the cough using opioids or reducing the rate of the noisy breathing, lowering the respiratory rate enough so that that sound of the noisy breathing isn't so rapid and loud. And opioids are often used for this, as well as some sedating medications. Anticholinergics, some examples of those are scopolamine, glycopyrrolate, or atropine. The benefits of this is that they decrease secretions of saliva, they decrease bronchial secretions at the submucosal glands, and they cause some bronchodilation. They're useful in high-risk patients with lung cancer and brain cancer, and it's useful once the patient is showing indicators that they are entering into the end of life phase. So usually when their PPS is about 20 to 10%. The incidence of terminal congestion increases to about 73% of patients in the last 72 hours of life when their PPS is usually at the level of 20 to 10%. So often when patients stay in this PPS of 20 to 10 for a prolonged period of time, 72 hours or more, they have a higher incidence of having respiratory congestion. It's useful if starting the medications to help manage this congestion at the point in which you start to hear them. Most patients are no longer alert at the time secretions start to build or build to the point in which they become distressing to family at the bedside. Their PPS is usually 20 to 10%, as I've already said. And the general belief is that patients are not usually distressed by them, but this is certainly distressing for family at the bedside. Studies suggest that secretions cause a moderately high degree of distress for the family. Family members will often be disturbed by the sound their loved one is making, such as it sounds almost like a slurping straw sound. It's important to reassure them that it's natural and not an uncommon part of the dying process, and it does not cause the patient to suffer. The noises are present because their loved one is not able to cough up or clear their throat of these normal secretions. The patient will not suffocate. The patient will not feel short of breath. Reassurance is paramount in the management of terminal secretions. There are a few non-pharmacological management methods that are helpful as well. Frequent turning side to side can be helpful. Positioning when the noise intensifies can be helpful, and minimizing parenteral fluids if they're still being provided. All of these are reasonable efforts to help decrease the buildup of those secretions and decrease the sound that you're hearing audibly, and they're not harmful to the patient. Suctioning is distressing for the patient. Deep suctioning may irritate the mucous membranes and may actually cause more secretions to be produced. Unless secretions are visible in the mouth, suctioning secretions should be avoided. Some of the most common medications used to treat secretions are scopolamine. The other name for that is hyoscine hydrobromide, and the dose is often 0.2 to 0.6 milligrams sub-Q, Q2 to 6 hours PRN. Glycopyrrolate is another medication that's often used, 0.1 to 0.4 milligrams Q4 to 6H sub-Q PRN. Atropine is often used, 0.4 milligrams to 0.8 milligrams sub-Q Q4 to 6H PRN, or atropine 1% eye drops 1 to 2 drops, 1 to 2 hours, PRN sublingually or buccally. And then buscopan can be used as well. The other name for that is hyoscine butyl bromide, 10 milligrams to 20 milligrams sub-Q, Q6H PRN. There's different side effect profiles to the different medications, which is why some are used in some situations and others are more preferenced. Scopolamine crosses the blood-brain barrier and causes more sedation and sometimes can contribute to a delirium. Excessive dosing of scopolamine can result in more agitation and delirium. Glycopyrrolate, on the other hand, does not cross the blood-brain barrier in any significant amount. Therefore, it's thought that glycopyrrolate may be a better medication in patients who are alert and bothered by their own secretions. Atropine can be used. It does have anticholinergic adverse effects that may last for hours, thus may be used in the end-of-life phase of illness when other or alternative medications are not available. Buscopan is an anti-muscarinic. It decreases the mucus production, but may not be as effective as hyoscine hydrobromide. It's important to consider the diagnosis and the goals of care when managing respiratory secretions. So if the secretions are pharyngeal or pulmonary secretions building up, if truly the person is in the end-of-life phase of their disease and these are end-of-life terminal secretions, then their PPS is usually less than 30% with the patient in a less responsive state. Common practice at this point is to start with intermittent PRN doses when using these medications to decrease the respiratory congestion or to slow the accumulation of further secretions. Patients may only require a few doses. Response to the treatment can be variable. Before moving towards higher and more frequent dosing, it's important to consider the diagnoses and the goals of care of the person and their performance status. Are there reasons for the secretions that are treatable, for instance, and is their performance status high enough that treatment would be part of their goals of care? So for instance, do they have a pneumonia? Do they have congestive heart failure? Is their PPS still, 40%, 30%? Are there other interventions that could be helpful that could turn this situation around a little bit before we start putting in some of those end-of-life medication treatment options? Consider discontinuing the parenteral hydration and using an antibiotic or a diuretic if it's warranted, if their PPS is higher and their goals of care are treatment focused, of course. Research evidence is not conclusive around the use of these medications. There are limitations to all of the studies that are done. More high quality studies are required for insight into both pharmacological and non-pharmacological interventions to manage the respiratory secretions at end of life. The following are just some general findings of some studies done that I found. One comparative study found that scopolamine was significantly more effective than glycopyrrolate in reducing the severity of end-of-life secretions about 30 minutes after the medication was given. But this effect was no longer present about an hour later or just before death. So it required some repetition in the dosage. One retrospective study found that glycopyrrolate was more effective than scopolamine. Two studies found that levels of hydration did not change the prevalence of terminal secretions. One study found no significant difference in the effectiveness or the survival time among patients that they used atropine, hyoscine butyl bromide, which is buscopan, or hyoscine hydrobromide, which is scopolamine, in the treatment of terminal secretions. But they did suggest that treatment was more effective when started earlier at a lower initial level of intensity, and that effectiveness improved over time, so after it was used a little bit. One randomized controlled trial that looked at atropine found no difference in results between patients receiving atropine and those receiving a placebo. A study comparing atropine and buscopan and scopolamine found that all three drugs decreased the intensity of terminal secretions um, after about an hour. And they decreased them enough to the point in which they were rated non-disturbing in their intensity. Further effectiveness improved with these medications over time without a significant difference among the different treatment groups. So there were 3 treatment groups in this study. One treatment group received atropine, the other one buscopan, and the other one scopolamine. And they found that in each of these groups that the effectiveness improved over time in each of those groups, regardless of what medication they were using. Treatment was more effective when started when the intensity of terminal secretions was at a lower level. So from the point in which you started to audibly hear the secretions, if treatment was started at that point, then the effectiveness was considered better. The average survival after starting therapy was on average 23.9 hours. There was no significant difference in the effectiveness or the survival time among the 3 meds used in the study to treat the terminal secretions. So using one or each of these different medications did not impact the survival time between any of them. Communication about terminal secretions with family members and others involved in the care of these patients is very, very important. And it's important to understand the symptoms that are present with respiratory congestion are part of the natural dying process and may help reduce family members' distress by explaining the normality of this. And these are the references that I used. And I thank you for your time.